it doesn't only affect the patient, it affects the whole family.
If you give lower dosages, there's less revenue.
In 1950, approximately 1 in 20 Americans would be diagnosed with cancer in their lifetime. Today, that number is approaching 1 in 2. In one human lifetime, we went from rare to nearly inevitable. This investigation is personal. Someone I love did not get to hear what you're about to hear. My mother was diagnosed with ovarian cancer, and like millions of families before mine, we trusted the process. We followed the instructions. We believed the system was designed to save her. She did not make it. And for a long time, I did what most people do. I grieved. I moved forward. I did not ask questions. Because when someone you love dies from cancer, asking questions feels like it might make the grief worse. But then I started reading. Not articles, not blogs, not social media posts. The actual studies. The peer-reviewed research. The court records. The historical documents that sit in medical libraries and government archives, available to anyone willing to look. What I found changed everything I thought I knew, and today, the Metabolic Files is going to share it with you. This channel is an investigation, not a prescription. Nothing in this episode is medical advice. Every fact comes from published, peer-reviewed research and documented historical records. Every source is in the description. Verify every word. This is part 1 of a 2-part investigation. Part 1 covers the history. Part 2 covers the practitioners who challenged it. Make sure you are subscribed so you do not miss part 2 when it drops. In 1930, the lifetime risk of a cancer diagnosis for someone born that year was approximately 38.5% for men and 36.7% for women. That is published in the British Journal of Cancer. By 1960, that number had risen to 53.5% for men and 47.5% for women. The researchers concluded, and I am going to let this sink in, that the lifetime risk of cancer for people born since 1960 is greater than 50%. More than half. Today, according to the American Cancer Society's 2025 Cancer Statistics Report, the lifetime probability of being diagnosed with invasive cancer in the United States is 41.6% for men and 39.6% for women. The United States projects over 2 million new cancer diagnoses in 2026 alone. 2 million families in 1 year, and perhaps the most alarming trend of all. Cancer is no longer primarily a disease of the elderly. The proportion of new diagnoses in adults aged 50 to 64 has been increasing, and researchers have identified increased cancer risk in people born since the 1950s. The disease is getting younger. What changed? What happened between 1950 and today that turned a relatively uncommon disease into something approaching a statistical certainty? The answer involves a war, but not the one you think. During World War I, a chemical weapon called mustard gas was deployed on the battlefields of Europe. It blistered the skin. It destroyed the lining of the lungs. It blinded soldiers permanently, and physicians treating the survivors noticed something unexpected. The gas severely damaged bone marrow and destroyed lymphatic tissue. White blood cell counts dropped to nearly zero. That observation, made in the trenches of a world war, planted a seed that would grow into the most widely used cancer treatment on Earth. In the early 1940s, after the United States entered World War II, the federal government launched a classified program to study chemical warfare agents. At Yale School of Medicine, 2 pharmacologists, Goodman and Alfred Gilman, were assigned to investigate nitrogen mustard, a derivative of the same mustard gas used in the trenches. In their laboratory, they exposed mice with lymphoma tumors to nitrogen mustard. The tumors shrank dramatically, but because the research was classified military work, the compound could not be referred to by its real name. It was designated Substance X. Working with surgeon Gustav Lindskog, they identified a patient with advanced lymphosarcoma who had exhausted all other options. The patient was a 47-year-old factory worker from Connecticut, known in medical literature only by his initials, JD. On August 27, 1942, at 10:00 in the morning, JD became the first human being in history to receive intravenous chemotherapy. The result was dramatic. Within days, his tumors began to soften. By the 10th day, they were no longer detectable by physical examination. For a brief window, it appeared that Substance X had achieved something remarkable. Then, the tumors came back, aggressively, resistant to further treatment. JD received 2 additional courses. Neither worked. He died 96 days after his first injection. The first patient ever treated with chemotherapy died within 96 days, and nowhere in his medical records do the words nitrogen mustard appear. Because the substance was classified. Because the research was secret. Because the treatment was born from a weapon of war, and the government did not want the public to know. In 1949, the FDA approved mechlorethamine, a nitrogen mustard compound, as the first chemotherapy drug. The era of chemical cancer treatment had officially begun. Its origin was a chemical weapon. Its first patient survived 96 days, and the public was never told how it started. Chemotherapy works on one principle. It targets rapidly dividing cells. Cancer cells divide rapidly. Therefore, chemotherapy attacks cancer cells. But here is the part that gets left out of most conversations between oncologists and patients. Cancer cells are not the only rapidly dividing cells in your body. Your bone marrow cells divide rapidly. They produce your blood supply. Your immune cells divide rapidly. They defend you from infection and disease. The cells lining your digestive tract divide rapidly. They allow you to absorb nutrients from food. Your hair follicle cells divide rapidly. That is why hair falls out during treatment. Chemotherapy cannot distinguish between a cancer cell and a healthy, rapidly dividing cell. It attacks both. A peer-reviewed study published in Naumann-Schmiedeberg's Archives of Pharmacology in 2023 documented that chemotherapy directly damages immune cells through cytotoxic effects, alters their ability to differentiate and function, and disrupts the signaling pathways they use to communicate. The result is profound immunosuppression. The very immune system that is supposed to fight the cancer is weakened by the treatment designed to fight the cancer. Research published in Breast Cancer Research studied 88 breast cancer patients and found that the adaptive immune system remained significantly altered for at least 9 months after chemotherapy ended. Certain immune cells, particularly CD4+ T cells and B lymphocytes, had not recovered to baseline levels even a full year after treatment. A study published in Cancer Discovery by the American Association for Cancer Research in 2024 stated it directly. Patients receiving cancer chemotherapy are immunocompromised, make poor antibody responses to vaccines, and are at increased risk of life-threatening infections. The study further documented that alkylating agents, the direct descendants of the nitrogen mustard that killed JD in 1942, cause DNA damage, mutagenesis, and can lead to secondary malignancies, meaning the treatment itself can cause new cancers. In 2004, 3 Australian oncologists, Graham Morgan, Robin Ward, and Michael Barton, published a meta-analysis in the journal Clinical Oncology. All 3 were credentialed cancer specialists. Morgan was a professor of radiation oncology at Royal North Shore Hospital in Sydney. Ward was a senior specialist in medical oncology and a member of Australia's Pharmaceutical Benefits Advisory Committee. Barton was a research director specializing in cancer outcomes. Their study examined every randomized controlled trial published between January 1990 and January 2004 that reported a 5-year survival benefit attributable solely to cytotoxic chemotherapy for 22 major adult cancers. They used data from both the Australian Cancer Registry and the United States SEER database, and wherever the data was uncertain, the authors stated they deliberately erred on the side of overestimating the benefit of chemotherapy. Even with that deliberate bias in favor of chemotherapy, their conclusion was below it. The overall contribution of cytotoxic chemotherapy to 5-year survival in adult malignancies was estimated to be 2.3% in Australia and 2.1% in the USA. Below that, Morgan, Ward, Barton. Clinical Oncology, 2004, 2.1%, published in a peer-reviewed oncology journal. Written by 3 practicing oncologists, using the gold standard of medical evidence, randomized controlled trials. This number is one of the most contested statistics in all of oncology. Critics argue the study excluded certain cancers where chemotherapy is highly effective, such as testicular cancer and childhood leukemia. Supporters point out that the study examined 22 major adult malignancies, which represent the vast majority of cancer diagnoses, and that the authors were oncologists themselves, not outsiders with an agenda. The Metabolic Files is not telling you this number is the final word. It is telling you this number exists. It is published. It was written by credentialed oncologists, and most patients have never been told about it. The question this investigation leaves with you is simple. If you or someone you love is facing a cancer diagnosis, do you want to make that decision with all the published data, or only the data your oncologist chooses to share? That is the history. A chemical weapon became a cancer treatment. A classified experiment on a man known only as JD became a global medical industry. And a published meta-analysis by 3 oncologists found that across 22 major cancers, the overall contribution of that treatment to 5-year survival was 2.1%. But this investigation is only half finished, because while the mainstream medical system was building its entire cancer treatment infrastructure on the foundation of a World War II chemical weapon, there were other practitioners who tried a different approach. Some were medical doctors, some were not. Some were indicted, some were acquitted. Some brought patients to court who testified, under oath, with documentation from licensed physicians, that they had been made well. Part 2 of this investigation covers every one of them. Their treatments, their evidence, their court cases. Both sides, every source cited. If you are not subscribed, do it now. Because Part 2 is the episode that changes how you think about who gets to decide what treatments are available to you and your family. Every source from today's episode is linked in the description. Read them. That is the entire point of the Metabolic Files. This channel is not operated by a medical professional. Nothing presented constitutes medical advice, diagnosis, or treatment. All information comes from published peer-reviewed research, documented historical records, and publicly available regulatory filings. Consult a qualified healthcare provider before making any decisions about your health. And if this episode made you think of someone, a parent, a spouse, a friend, someone who fought this disease or is fighting it right now, drop their name in the comments. Not for the algorithm, for them, because they deserve to be remembered. And send this video to someone who is fighting right now. They deserve to know what the published research says. The truth is out there. I will see you in the next file.